Good morning, everyone. Today, I'm going to present a headway in an already known phenomena, a tale of two diagnoses. A 35-year-old female presented with diminution of vision and redness along with a headache and vomiting in both the eyes. On examination, the findings were similar in both the eyes. There was diminution of vision along with cornea hazy with microbullae, and AC was uniformly shallow throughout, and the pupil was mid-dilated and non-reactive, while the IOP was raised in both the eyes. So the first question was, why bilateral angle closure why a bilateral angle closure attack? Like we all know, the most common mechanism is pupillary block, which is usually unilateral. But yes, it's rare, but it's possible. So the first thing, rarity, was the diagnostic dilemma. Then we considered some risk factors causing bilateral angle closure in our case. So she could be, as she's a female, she could be hyperopic. Thickening of lens would not usually be present because of her age. It could be drug induced, could be plateau iris configuration, but we'll see that on gonioscopy. On doing biometry, she was not hypermetropic as the axial length was around 22.7 in both the eyes. Then on taking a detailed history, we found our culprit. She was on topiramate just 7 days prior for a pre-existing seizure disorder. Then after consultation with on-duty neurologist, she was withdrawn on topiramate, and the IOP was controlled simultaneously on anti-glaucoma medications. After the cornea cleared, AC was still shallow with inflammation. B-scan findings and ASOC findings also showed ciliocoroidal effusion, which was pointing towards topiramate. So we felt the case was simple and it's closed. It was seemed to be bilateral angle closure attack post topiramate. But on follow-up, the story which we saw was not pointing towards this. There was synechiae in both the eyes, while the fundus was normal in both. And also, even after 2 months of follow-up, the AC was shallow, there was inflammation, left eye had IOP raised, and there were some glaucomatous changes that seemed to be appearing in left eye. So was that just an angle closure attack or a masquerade of uveitis? So there was persistent inflammation that was not responding to steroids, and there was extensive past development. So this patient had drug-induced angle closure attack. Why would the inflammation had so long? And that was not responding to steroids, and there was synechial closure in both the eyes. So it was pointing towards chronic infectious something. So we knew that the peripheral iridotomy was a ticking bomb, but we took a chance to prevent further ocular damage, and we did peripheral iridotomy, and concurrently the complete uveitis panel was initiated to investigate an underlying inflammation cause. This was the picture post PI. On investigation, it revealed that she was HSV IgM positive, but the cornea was absolutely clear and there was no signs of herpetic keratitis. So it was herpetic uveitis with no corneal involvement. On digging literature, we also found that almost 1/3 of the patient can even present without corneal involvement in herpetic keratouveitis. The patient was started on oral acyclovir. So the clinical response to oral acyclovir was excellent, with a significant reduction in inflammation that further confirmed the etiology. So the final diagnosis was both eye mixed mechanism glaucoma with added angle closure attack. So in conclusion, the case began to simply look like just a classical drug-induced angle closure, but the atypical progression, steroid-resistant inflammation, prompted us to look for a masquerade syndrome. So this brings to take-home messages. Firstly, recognizing masquerade syndrome after an acute event is important, as it can unmask the underlying chronic disease. Identifying red flags is important. Expand the differential diagnosis, and the most critical messages: vigilant follow-up is critical and most revealing than the initial emergency presentation. Thank you.
Yeah, Niharika, very interesting case. This shows the importance of regular follow-up in a patient, even otherwise of angle closure disease.
Yes,
because what happens is you diagnose the case of either PAC or PACS, and the patient does not come. You do laser iridotomy and leave the patient. Patient goes back and never returns, thinking that his treatment has been done and no follow-up is required. It was only I think your history revealed that topiramate was the cause of acute rise of intraocular pressure to 57 and 64 in both eyes. So whenever you have bilateral angle closure, you have to think of causes like this only, because otherwise bilateral angle closure is not a very common entity. It is mostly drug induced. So drugs like anti-migraine like topiramate or antipsychotics, they anticholinergics, they can cause the acute rise of intraocular pressure. And your vigilant follow-up where you found that the inflammation is still persisting, that led you to was the intraocular pressure controlled, or IOP was also remained high?
So it remained high up to 2 months till
How
follow up.
much? How much was IOP?
It was around in 20s and 30s.
In 20s and
Yes,
30s.
sir.
Okay. Oh, right.